So we will start. Long awaited. I think almost everyone was waiting for this lecture because this is an important topic, and we keep finding there are a lot of ethical dilemmas when we do palliative care research, especially in these days when we are giving research topic to MDs, and we realize many times that this research should not be done because this is not ethically correct or something like this. So what are the ethical dilemmas, and what should we be doing to sort out these dilemmas? I think that no one can be better than Dr. Fiona and Dr. Santosh together. And Dr. Fiona will tell us what are the ethical dilemmas, and then Dr. Santosh's comments will supplement in what we should do in Indian scenario, and how wherever we like in Indian context, what can be exactly done. So I think introduction, I should not waste time because we all know who is Dr. Santosh and who is Dr. Fiona. But I want to say something about Dr. Santosh, that Dr. Santosh, although in these days he is in UK in Lancaster University, but he is the favorite teacher of all of us as far as communication workshops are concerned. So a whole AIMS students, they remember his communication workshops, and he has received many awards from India. So I think probably he will come back very soon to India. And his area of interest mainly basically in communicating people with chronic pain, and probably he may get a plenary lecture in Iapc on this topic. And his instruments and he's very good in development of his instruments and skills, and he was a very important person who has helped us in developing his spiritual skill. As far as Dr. Fiona is concerned, I think Dr. Fiona, we all know you. There are many students of yours, those who have done diploma palliative medicine and MSc palliative medicine, including me, who has done MSc palliative medicine from Cardiff University. And you are means like I was not knowing all these awards because we love you as a teacher. But when I read your awards that you received the winner of Medical Star Award to 2021 for inspirational leadership in teaching, I think this was such a suitable award for a right person. And you have also received Center for Medical Education nomination for Teachers Award, that is Sargam, outstanding clinical and academic commitment during pandemic. This was also we were not knowing. So I am just reading all those which I think many of us are not knowing. And your area of interest, we all know that you teach very well palliative care, end of life care, and communication, team working, mentorship and leadership, and how we should take the palliative care education further ahead. And right now, Dr. Fiona is working as a reader and postgraduate course director in postgraduate palliative medicine care, Cardiff University, and she is a mentor of many of us in this country. So without wasting time, I think I will request Dr. Fiona and Dr. Santosh to take care of next 1 hour, which everyone is waiting eagerly. Already 73 people have joined, and I think many of them will join very soon. Dr. Fiona.
Thank you so much, and thank you for all the introductions. And yes, Dr. Santosh and I had some long conversations on email and last week about how to present the session, because there are ethical issues around research, but there are also so many ways that you can enhance your research by working closely with your research ethical committees. And so how we thought we would split the hour is that I would just really talk about the foundations of the ethical principles in research, and then hand over to Dr. Santosh to really do the practicalities of conducting research within the Indian context. We are happy to take questions through the chat, and I'm just now going to share my screen, I hope. And what I just need to do, Dr. Santosh, you are in my sites. Is my screen sharing?
Yes, ma'am.
Yeah, it is. Yeah, it's come.
Lovely. Fantastic. Okay, thank you. Right, so here we go. Fasten up your seatbelts. This is going to be a quick lot of information, but much of it I think you will know in your heart already, but it's useful to take time. We're going to think about why research is important in palliative care. We're going to think about the ethical framework, think about issues faced by patients and by us as researchers. But it's not just the research itself we're going to talk about. We're going to talk about publishing and presenting our findings, because ethics runs through research right from the moment that you have that question, you have that wonder, you have that curiosity. I need to know more about this. But then ethics runs right the way through up until and beyond that moment that you share those results. It's not just about methodology, it's about the results, it's about the sharing of the results. So understanding the framework is vital. And I think the first question to ask ourselves is, what are the unknowns in palliative care? And I think we could spend a whole afternoon a whole evening looking into this. There are so many unknowns about palliative care. There are the domains. We need to know more about physical symptoms and physical symptom management. We need to know much more about psychological and spiritual adjustments to end of life. The world is diverse, cultures are diverse. What can we do to know more, to make our delivery of palliative care to our patients better? Palliative care, as you know, it's not just about death, is it? Palliative care is about living. What can we find out to make people living with incurable conditions live the best life they can for as long as possible? And of course, what about prognostication? It's really difficult to predict when death is going to happen. There are still so many unknowns in palliative care, and put that together with a particular context of different countries, we need research, we need more of it. What's the intrinsic value of research? It gives us knowledge. Research gives us knowledge, sometimes without practical benefits, but it gives us knowledge, and we need that evidence base for palliative care. We're not like the cardiologists or the stroke physicians, but particularly cardiologists have millions of patients. They do millions of randomized controlled trials. They can, because they've got the number of patients. It's more difficult, isn't it, with our palliative care patients? So we need to make sure that we have got the research. We need to offer the most effective and beneficial treatments. We need to avoid the unsafe, but particularly the ineffective treatments. Palliative care patients have not got time. They've not got time for us to try things. For them, every second of every minute of every hour of every day has value. Their heart is still beating, they are still breathing. So we need to make sure that we're not offering ineffective treatments. So we have to know more. Research helps us to know more. Think a little bit more broadly, just to keep your research ideas in context. Of course, there are human subjects, but don't forget, there is research around cell cultures, animals and tissue samples, and some of those will still be relevant to palliative care. I think for the purposes of this talk, I'm thinking concentrating much more on human subjects. So, what are the challenges of conducting research in palliative care? You know all of this. The challenges are many and various, aren't they? We look after frail, vulnerable patients who may or may not be able to consent. They may die within the next few days, weeks. We have limited resources. There is a public attitude to death and dying, and there are some spheres of the public that don't think that it is ethical and right to conduct research on dying patients. Actually, knowing the research skills is important. Those of you who know me well will know I'm passionate about picking the right methodology for the right research question. So randomized controlled trials don't necessarily answer the questions we want to know about in some of our palliative care research. They're great for pain control, but not so good for spiritual issues. The emergence of qualitative research methodologies is really important for some of the in-depth questions about sensitive topics. So there are many, many challenges to conducting research. However, I'm going back to where we started. We need research in palliative care. we need to know more so that we do not give our patients ineffective treatments and waste their time. Time is so precious, but we need to know how we can deliver palliative care. So we as healthcare professionals, whatever your discipline, in fact, we have an ethical duty to undertake research or to implement the results of other people's research, and it underpins evidence-based practice. So let's get on to ethics. That's the preamble. Let's get on to ethics. And as we go through, think of the patients you look after. Think of your family. If it was a member of your family that somebody involved in palliative care wanted to involve in research, what would you want your family member to be experiencing in terms of consent, etc.? Go back to Beecham and Childress, these pivotal 4 ethical principles: respect for autonomy, beneficence, doing good, non-maleficence, not doing harm, and justice, fair allocation of resources. Keep those 4 principles, print them out, take a picture of the screen. These are fundamental. They go through our clinical work, but they are fundamental to research as well. The World Medical Association's Declaration of Helsinki is a really important thing to read. As you're thinking about, as you're curious about research, you don't even have to be thinking about how to do it, but you need to read particularly the first page of the Declaration of Helsinki. In the UK, we've got the GMC's Good Practice in Research, and I'm absolutely certain that you have equivalent in India. But the real important thing about this is look at the general principles. The health of my patient will be my first consideration. So you might have got the most exciting idea for the best painkiller, or a completely new tool that you want to explore people's spiritual and existential meanings and get under this, really get into those so that you know how best to support people. You might be enlightened, you might want to know about anticonvulsant medication. Whatever it is, the risk is that you will be so excited, your intellectual curiosity will take you so many miles away from the patient. You have to bring yourself back, and the health of the patient will be your first consideration. And it is so easy. We don't forget it. We don't forget it willingly, but we can all get carried away on a research idea. Think of coronavirus. Wow. Going back to the Declaration of Helsinki for the early, particularly the early coronavirus research, was fundamentally so important. So we need then to promote and safeguard the health, well-being, rights of patients. So Declaration of Helsinki is a must read. I'm going to think about justice first. Thinking justice being allocation of resources. Is it the funding for research? Is it the funding to implement the results of the research? And actually, I'm going to take this back one step further and say, as you're thinking about that research idea, is it justifiable in its aims? What do you want to achieve? What do you hope the outcome's going to be? Is it okay in terms of using the resources, whether they're financial, material resources, human resources? Is it going to take too many people away from the clinical workplace to undertake this research? Have you got the people you need to be able to do that research project? The answer to that is thinking creatively, maybe yes, but you need to think widely around justice. And I firmly believe that thinking ethics of research, you don't just take one of the ethical principles, you look at one, but you have to put it in relation to all the others. Respect for autonomy, fundamental, and I'm thinking particularly around consent now. So consent needs decision-making capacity. It needs to be voluntary. It needs to have information. And the information has to be very clear about the risks of participation. And if it's a clinical trial, for example, 2 different analgesics, if you're going to use randomization, how is that going to be done? How is the blinding going to be done? But there is this concept called therapeutic misconception, which is the possibility that individuals might fail to distinguish between research participation and clinical care. And we do see this quite often. People wonder if they're going to be involved in research, will they get a better clinical care? They may get blood pressure checks more often, for example, if you're using an intervention that might affect blood pressure. However, it's really important that you consider that, and that there is not any unfair advantage, and you're very clear that it's not going to impact on patient care. And think about the perception of the patient who has that condition of interest and the patient who doesn't. So how are you going to manage things if unexpected findings come up during that research? So therapeutic misconception is really important, and it's about what we write in our information leaflets. Interesting and difficult, and we'll come on to this, I'm sure, in the second half, depending on where you're researching. People, particularly with COVID, they're not travelling to centres as much. So that length of time between giving information and allowing people to have enough time to process the information is not so easy, and it's not always in person. If somebody's going to come once every even 2 or 3 months because travelling from their remote location into the centre is difficult, time-consuming, costly, if you're interested in them as a research participant, how are you going to manage that? Mental capacity to participate in research is fundamental, and it's not just the inability to communicate, because some people have acute mental capacity but have an expressive dysphasia, for example. You cannot expose a subject to risk of harm without consent. So you need to think about, actually, on the wider scale, do you ask for consent in advance? Can you do that? Do you know enough information about what might be proposed? Think about the culture of communication. Talking about advanced decisions and advanced care planning is challenging enough anyway. So it's just, I haven't got all the answers, but I'm just highlighting some of the ethical dilemmas that are going to come up. But you might find some people have thought about this, have already expressed preference. Does the carer or decision maker have a role? What role does that have in respecting the autonomy of the patient? Again, we haven't got clear answers always, and for every research project, every research that is undertaken, it will be slightly different. So these are general principles to think about each time. What about improving recruitment? We know that numbers in palliative care trials are terribly small. So do you offer money for travel, for example? The trouble is, does that then give potential coercion of subjects? Possibly yes. Is there a bias in the subject selection? People will come if they know that there's an inducement to recruit, to improve recruitment. So generally, the answer is no, you can't. And no, it might have all of these adverse effects to think about. And confidentiality is key. It's just like medical practice. It's just like your clinical world. However, there's a problem, isn't there? Because once you've done your research, you're going to need to release information, either to other healthcare professionals if you're doing a cluster trial with other people, and to publish things. So how do you do that? You need to anonymize, you need to be clear how you're going to handle data, who owns the data, where are you going to store it, how are you going to anonymize it, how long are you going to keep it for, and in what format. And people need to know this before they consent for recruitment. And you cannot publish identifiable data. It is unethical to publish identifiable data. And I think there's probably something to do with actually how we're feeling as well. So what about epidemiological studies rather than the randomized trials or the treatment-based? Actually, can you do things prospectively? But as we said a little bit before, with the people who haven't got capacity, actually, it's hard to look ahead. Who could have thought that COVID would come along? So, in fact, is a consent given 2 or 3 years ago, is that still valid? Probably not. Have people got a right to opt out? Yes, of course they have, but will they remember to do so? So thinking prospectively, just think about how you can, how could you do that? How could you build that in to your methodology? And retrospectively, the trouble is, if we're going to look back, we probably won't have consented people with enough information for them to be clear what they're consenting to, unless there's going to be real significant benefits to the individual or society. And the great thing is that you have the resource of the Research Ethics Committee, which we'll be talking about in about 5 minutes' time. If you put all of this stuff to them, they will then help decide what is the best, most robust ethical way to conduct research. Benefits and harms methodology. All bad science is unethical. Some good science is unethical too. Think of the aims of the study. Think of everything all together. What do you want to achieve? And are the harmful effects justifiable? All volunteers are at risk of harm. And if a trial somewhere has produced valid results, then actually it doesn't need repeating. I think my only possible counter to that would be if a trial has been undertaken in a population that is very different to yours, then actually is there benefit in repeating that trial in your local population? Question mark. The ethics committee will help you decide that, but much better to have thought it through before you potentially waste time and resources and money on doing something that doesn't necessarily need to be done. So what's difficult is that you'll have your really clever research ideas that will be burning a hole in your brain, and you'll be desperate to get on with them, and actually sometimes you need to be flexible enough to modify them. If somebody else has done it before in a population not unlike yours, actually, is there a slightly different area that you can explore? So I would never put that flame out of curiosity and passion and energy, but you might just need to steer it in a slightly different direction. And if there has been a methodological flaw, then it needs to be repeated. Volunteers who don't necessarily have that condition of interest, it is ethical to involve them in research, but the potential benefits must outweigh the risks. And the volunteers can be patients with other conditions, they can be healthy volunteers. But again, think of the aims of your research, and the ethics committee will review. When you're thinking about medication, the really important thing is this thing called equipoise, which I'm going to come on to. You cannot randomize people to a substandard of care. So if you're wanting to look at, for example, a new analgesic or something new for nausea and vomiting, you need to be comparing it to the most effective alternative. So you can't randomize, you can't subject people to a substandard of care. Same thing could be applied to placebo. I'm getting a little bit conscious of time now. So placebos are not a problem for healthy volunteers, but again, is there no alternative treatment? So you can't be subjecting people to a less standard of, and this thing called equipoise, and you read this in the research methodology and in lots of the papers around research methodology. It's an assumption that there isn't one better information that's present. And this is all around. And so if you're explaining this to colleagues who say, well, it's not right, it's not right to be doing, we shouldn't be doing research into vulnerable patients. How are we going to learn about palliative care and deliver better palliative care if we don't do research? Being able to explain this concept, I think, is really important. The other way to get around equipoise is, and this is relating to the fact if you are involved, for example, in a ward where you use a lot of chemotherapy for cancer patients, and you've come across, for example, the work in olanzapine by Anna Sutherland and colleagues in the UK. It might have been just a chance observation that people on olanzapine for their depression didn't seem to experience the same amount of nausea and vomiting as other patients do. You've got that belief, you can see it, but actually is that knowledge? And how are we going to explain that? And sometimes if you want to increase your pool of research subjects of patients, using things like a cluster randomization or cluster trials is a very good way of increasing the numbers. But you need to think, okay, I can't harm my patients. The Helsinki Declaration says I have to look after the health of my patient. If you're monitoring things through a research project and through a trial, if it's clinical research, at what point do things become significant? This is where your statisticians will help you. Can you stop recruiting early? The trouble if you stop recruiting early is you may miss some of the later side effects of that intervention. So actually having a committee around you to help you make that decision is really important. And so this is what I mean by saying the difficulty is you may be so excited by the findings, sometimes it can blind you as a researcher. I think when I say blind, I'm meaning you can be so caught up in the findings and the excitement, and it may be something really new, that you stop being objective. So having people around you who can help keep you grounded and say, hang on a minute, yes, this is what it looks like, but we need to keep this going for another few months. We need to make sure there are not late complications. And again, I think when we look back on some of the research in coronavirus, we're going to find that there have been unwittingly some challenges in some of that research. So non-therapeutic research, it's not directed to the health of present patients, but establishment of conclusions. Again, it's just thinking, is this research around different ways of service delivery? Is this qualitative research? Well-being of the subjects should take precedence. So for example, if you want to do qualitative work around communication skills, around talking of death and dying, around talking to relatives about the last moments of their loved one, you need to make sure that you've got robust methodology and you've got a real distress protocol, because if you're interviewing carers and relatives, you need to know what are you going to do if they become distressed, because that distress would be harm in a research project, in research against the Declaration of Helsinki. So although I've talked a lot about clinical research, I also mean this exactly the same for qualitative research as well. Moving on, last couple of minutes, interpreting the data. Ethics is vital here. We've just talked about, you're so excited. Actually, have you wrongly attributed meaning to the trends? Have you wrongly attributed meaning or inappropriately attributed meaning to qualitative research? That may lead you unwittingly to misinterpret the data. You publish the data, people base their treatment conditions on your data, and you can see where one simple error or error of judgment could lead to clinical harm. So if you're doing qualitative work, you have to attend scrupulously to the quality measures. Double reviewers, for example, explicit methodology, and be very critical of your findings, conclusions, cross-check and cross-check and cross-check again. So always keep on these 4 pillars. And then publishing and presenting. Why do we do it? We want to gain new knowledge. But we need to present the work. Even if the research didn't yield the results that you expected, even if the research had to stop because of some difficulty, we need, as a palliative care community, to know that, because you're going to stop other people from making the same mistake. So you're contributing to justice in future research designs. It's an integral part of disseminating the work. But how are you going to present the data? Is it legal? Beware plagiarizing other people's work. Beware collusion in the research team. I strongly advise you to ensure author order and precedence before you publish, just so that everybody is clear in what order people are going to be on that in that publication. And just it's transparency. Ensure conflicts of interest are clearly outlined. Have you been lucky enough to get a grant? That's great. Put it down. It needs to be down somewhere. People need to know where the funds have come from. So open transparency is really important. So 25 minutes Dr. Santosh, perhaps 5 or 10 minutes longer than we thought, but it's better than it was first thing this morning, because it was about 40 minutes this morning. Here we are. We've got an idea. We really, really, really want to do research. Talk to people, involve people, share your ideas with safe people, including lay people if you can. But at some point, you are going to need to talk to your local ethics committee. Time is not lost. All the preparation you do for your local ethics committee, that will form your introduction and your methodology of that writing a paper, of that research award, whatever it is. So time is not lost, but it's really important that we take things further. Stop sharing my screen now and hand on to Dr. Santosh to keep on going. I hope I'm going to stop sharing my screen. Hold on. There. I am going to stop sharing my screen. There we are. Over to you.
Yeah. Thank you, Fiona. That was amazing. I think it was very comprehensive, and it gave the general framework. I know most of the people in the audience are, quite experienced, and as you said, ethics is actually in the heart. It's not so much in the guidelines, but it is in the heart. If you are ethical and you do what is right, then you don't need guidelines and various other things. Well, from a practical point of view, let me see. I just have one slide to show, and that will cover the important things which Fiona has mentioned. One is about the ethics guidelines, and in research, medical research in India is governed by the Indian Council of Medical Research. And I hope people have access to that. And let me see if I can do that. Yeah, so this has 4 links which are very important. Number one is the Icmr ethical guidelines, which one can find on the website. The latest guidelines were in 2017, and it is the second bullet shows the PDF of that, which you should download. More importantly, with the pandemic in 2020, Icmr was quite proactive, and they made the amendments to the Icmr guidelines, which are in relation to the pandemic, and that is also there as an addendum for Icmr guidelines 2020. So those two are there. Then we have the drug controller, or the Central Drugs Standards Control Organization, CDSCO, GOVIN, which again gives the ethical guidelines and how to get the how the ethics committees can be formed and what should be the ethics committee. And this is the organization which gives approval to ethics committees, which at first time is for 3 years, and then it can be renewed subsequently. All the ethics committees have to be registered with the Icmr and the CDSCO. And when Fiona mentioned about publications, I think anybody who's interested in research and should be interested in publishing, because otherwise it's unethical to do research without publishing, should read the guidelines for from the ICMJE, which is the International Committee for Medical Journal Editors. This gives all the guidelines about who can be an author, what should be the order of author, how should you give conflict of interest, how should you mention about the various ethical things which are there. So it's a very interesting document, and it has grown quite a bit. I mean, it talks about publishing ethics, it talks about the various research misconducts and frauds which can be done and how they can be avoided. It talks about plagiarism and what is plagiarism and how it can be minimized and reduced or avoided. So I think all researchers should be in India should be familiar with these and be able to take this up. Next, of course, is my email address. So if there are any issues and problems, you can always contact me about dilemmas that you have about ethics committees. So yeah, so we have some questions.
Yes, we have some questions, Dr. Santosh. So would you like to take question one by one?
Yeah, I'll let me start with them. And first one is very interesting, and I think Fiona can add. How to get consent for online questionnaire-based studies? Is mere filling up the form an implied consent? No, just mere filling up is not an implied consent. There are two steps to online questionnaire-based research. Firstly, it should go through a local ethics committee, okay? And secondly, there should be a section where, or a box where a person can tick and say that, yes, I agree. Only then the rest of the questionnaire should come. So, you know, it would say that if I tick on this, I agree. Even more, if you want to be on a more ethical, standard, then you can give a box in which a person can write, I agree. But to make it simpler, there can be a box in which they can tick, and there should be a software which would say only after ticking, the rest of the questionnaire would come. Right. Alice has asked, how do you get consent in a case of time-limited trials, especially if a patient is unconscious or has mental incapacity? Alice, there is no such thing as time-limited trial. All trials have their own time, and you know it, isn't it? And if a person is unconscious or has mental incapacity, then first of all, since they will not be able to consent, you should try to avoid studies on them, but then that is also unethical. How would you get knowledge and information about people who are unconscious or who are mental incapacity? So in such situations, there are a few things which should be done. One is, of course, it should be monitored by it should not only be approved by the ethics committee, there will be a much more detailed discussion in the ethics committee that why do you want to study in an unconscious person or a person who has mental incapacity. That is number one. Secondly, you should always take a consent from a nominated representative of the family, which is usually a family member or a guardian or a spouse or anybody like that. If they are not there, then there should be, guardians which have been appointed by the society. And if it is possible, you should include people who have given advance directives. You know, they should say in future, like if I say that tomorrow, if I become unconscious, please include me in a study. Okay, so I have taken these two questions, and let me take Fiona's comments on these, then we will take the rest of the questions. Yeah, Fiona, about online studies and about unconscious persons.
Fab, thank you. Online studies, absolutely agree. And there will be there will be guidance on the best way to get consent. But if you need to think of it as there needs to be a point where people can read a paragraph and then stop. So having an actual, they have to do an action. They have to tick a box to go on to the next question. That's a physical brain, physical action that means that they have actually, yes, consented to go on to the next thing. And there's all, I'm sure, even if you just looked via Google for the best way to conduct online questionnaire surveys, there will be guidance on the best way to approach this. And absolutely, this is the fascinating area, thinking about mental people who are unable to give consent, and that terrible dilemma, because we need to know more about people who are unable to communicate with us, but actually how do you do it safely and respectfully, incorporating all those ethical frameworks? It would be amazing if we could get to the point where people were talking about that, making advanced statements, but actually as a palliative care community, we can throw that out to the wider society. It's part of these big conversations that we're having with our communities. But the other bit I'd just like to add in is that very often one feels a little bit adversarial about research ethics committees. And I've applied through many in my time. They want many words. They want you to have second thought absolutely everything that can go wrong. It takes time to produce that document, but they are your support and your friends as researchers. The research ethics committees want research to go ahead, but it needs to be done safely. So I'd really encourage you to actually think they are also your protection. As researchers in palliative care, potentially we are a little bit under threat from colleagues, members of the public, adverse publicity. And actually, if you know that your research has gone through and been approved by a research ethics committee, somebody, not you, has looked into it, and on those ethics committees will be all sorts of representatives from all sorts of different areas. So actually your research ethics committee is your strength and your friend and your protection. And I would, if during your application you start to get a little bit overwhelmed by, I've got another box to fill in, and I'm sure I've said this 3 boxes ago, in the UK we use something called IRAS, and that's exactly what it seems like. Actually, it's all for the good. So switch your thinking, really work with your research ethics committee, and then you'll get the best outcome, but your patients will be safe. And that's the important thing.
Yeah, Fiona, there is a reason for, the feeling which people have about ethics committee. Invariably, I mean, I've been in ethics committee for more than a decade. I have been the member secretary and members of a few committees. And I was really very amused because the members of ethics committee, they are always so stiff and serious, and anybody who comes with a project, they think that this person is a criminal, and they are always trying to put it down. So I tried to change it a lot, and I said we are all on the same side, and we should make sure that a research can be done safely, and it can be done with a proper methodology in an ethical way. It is not us versus them. And I think if people are interested, they should read a small commentary I wrote. Is it easy to be an EC member? And it's a satire. It's a satire on ethics committees. And because what people do, when I was on the other side of ethics committees as, submitting projects, I always had trouble with them, and even in UK, because I remember many years back, I submitted a project in UK, and they caught me on grammar. And not only on that, then they said, you resubmit the whole thing, So I thought that was a bit unfair, but then you never know, that's what I'm saying. Ethics committee members have a different type. Now, there are many questions, and let me briefly give responses to those. And then Fiona, I will request you to chip in with that. Now, one is from Pain and Palliative. How do we tackle problem of clinician and researcher being the same person who's doing qualitative in-depth interview? It is not a problem. It is an advantage because the clinician is there and a researcher is there. The thing is that you should have definite professional boundaries. When you are a clinician, you are a clinician. When you are a researcher, you are a researcher. As a clinician, you have your guidelines. As a researcher, your guideline is the methodology which you have done. So you have to follow the methodology. Methodology is sacrosanct. You cannot change a methodology after ethical approval. If you change the methodology, you go back to the ethics committee again. So, that makes life easy and it makes life difficult. Any guidelines for hospital ethics committee? I really don't know what this means, but if it means clinical ethics committee, yes. Every hospital which does palliative care should also have a clinical ethics committee to decide about difficult clinical decisions. But if you're talking about research committee, then you can have research committee. According to the Icmr, any hospital, any organization can make an ethics committee. And they have given guidelines how to make ethics committee, how many members should be there, how many should be internal, how many should be external, who can be the chairperson, who should be the member secretary. Just follow ICMR guidelines. And this is also in the CDS-CO website that I have written. How to develop guidelines of research for palliative medicine in underdeveloped countries where the knowledge of palliative care is not well known. I think Fiona mentioned in the beginning, palliative care is full of questions. There are numerous areas. You can study each and everything, you know, and so have a simple question. She also mentioned the importance of aims and objectives. Have a simple aim, simple objective, a methodology to answer that aim and objective, and then do that. So it's actually, you know, you are very lucky that you are in a country where not much is known and you can find out everything. How to manage ethical challenges in withdrawing life-sustaining. This is, I mean, I think it requires a separate session, Rabia, but otherwise, like I said, if you have a hospital ethics committee and various other things which I told, you know, about unconscious persons, that is what it can be used. Is it BG? Is it ethical to include children below 18 years after getting consent? No, consent from parents is not enough. There should be assent. Every child should be able to assent. If a child does not assent, assent means a child should also say yes. If the child does not assent, even if, like you have written, refuses to participate, even if parents consent, you cannot include that child. So both should give an assent as well as consent. Please explain about the criteria or requisition for registration in ICMR for a research study. Mamta, yeah, this is given in the CDS-CO website. What they require is, they require the members who would be there in the committee, their CVs, their consent, and then, you know, what is the aims and objectives, how frequently it will meet, all the, you know, terms and conditions for getting approval of the ethics committee. And similarly for ICMR, I'm not sure whether there is an application form, but if there is one, otherwise you need to send it to them and say that, you know, this is your ethics committee, which has been approved by the CDS-CO, and they can register it. How to get consent in studies utilizing retrospective data. So retrospective data, there are 2 points which I would like to mention. First of all, for every clinical situation, I mean, when a person gets registered in any hospital, we ask them to fill a consent form. It is usually very simple, in which it says that, you know, I agree for all the investigations and whichever interventions are done, and I will not blame the institute for that. So that is always taken. If it is not taken, then you should take it, you know. And when you are doing retrospective data collection or analysis, it is not exempt from ethical approval. You still need to send it to the ethics committee and say that we are going to do a retrospective data collection of, let's say, pain relief in our patients in last 3 years. But you also have to say that it will be only looking at the records, and that you will maintain the confidentiality of the records, and you will not contact the patients. Okay, because if you contact the patient, it is no longer retrospective. It becomes, you know, cross-sectional or prospective. So there are 2 things we should remember. Give, you know, take an ethical approval. Second, ensure that you will maintain the confidentiality of the persons whose record you are taking. Thirdly, you should not contact the patient. Now, since retrospective data is also very important because it is unbiased, you know, so it has an advantage, you know. So now what you can do is prospectively, whenever you are including a person in your clinical care, you can also take a consent in advance that we might analyze the data of your record 2 years later, 3 years later, 5 years later. Do you have any objection to that? If they have objection, you can remove them separate. You know, that is even being more ethical. Okay, was asking about guidelines for ethics committee. Yeah, guidelines for clinical ethics. Yeah. So there are no, actually, as far as I know, there are no special guidelines for clinical ethics committee, but they can be made. They can be, again, they should have a lawyer, they should have a ethicist, they should have a social worker, they should have a mental health professional, they should have clinicians, they should have pharmacologists, and they should have, admin people who are there. And then they should have guidelines on how you would be able to take a decision or help the clinicians take a decision. As ma'am told, it is unethical if a research shows any kind of harm to the patient. Are there any criteria for kind of harms in palliative aspect, since harm is a broad term and almost all medications? Well, I think I'll leave it to Fiona to answer this. But I think she never meant, obviously all drugs will have this thing, but it should not be a major harm, firstly. Secondly, it should be not be a harm which a person does not know. So we usually tell the person that, these are the side effects, these are the harms. If we are going to give morphine, then this is likely to happen. So, and anytime when they don't want to accept the harm, they can opt out. They can opt out at any stage of the trial or of the study. They might do it at the last minute or at the second last minute or anything like that. Yeah, and as Anjum has reminded, this will be covered in a session on national conference. Yeah, I was going to tell Anjum, she doesn't trust me. There will be there's a pre-conference workshop on informed consent in palliative care with the Yoris, Anjum, Charu, and myself. And please register for that. And now, Fiona, would you like to add on to the responses that I have given, and especially this one about harm?
Fantastic, thank you. I'm not sure I've got anything else to add about harm, in the sense that if you're using a treatment that is well established in palliative care but might have harmful side effects, if that's what the best practice is, then that will be accepted by the ethics committee. You need to have it very clear what you will do if your patients experience harm. What is your protocol for managing, for example, the side effects of strong opioids? Going back to, I'm just going to sort of take them in slightly different orders. Going back to the question about the researcher being a clinician, let's start with that one. I have a particular passion about this one, and this is about the robustness of qualitative research as well. And it's about, you can't separate where your brain is, but you need to know which hat you've got on, which role you have got. And I think it's particularly challenging in qualitative research, where you are recording an interview. But there's a concept called the reflexivity of the researcher. If I read a paper, a qualitative paper, if I review a qualitative paper, and I have read, if I don't know who has undertaken the interviews, that to me is already a question, because I'm thinking, right, what has this researcher tried to hide? Because I want to read a qualitative research paper knowing exactly how that research has been done. But there's something called the reflexivity of the researcher, where you are transparent in your research that, yes, I am a clinician, but because of the additional knowledge of the subject area that being a clinician gives me, it allows me as a researcher to explore some of the responses in greater depth, and therefore get a greater depth of data, of information, of understanding. But it needs to be really clear. But here's a really practical top tip now for those of you who have not yet undertaken research as clinicians in using qualitative methodology. Try it, because what you need to have up your sleeve is your script for when the research participant in front of you divulges something that actually needs your clinical attention, or becomes unwell, or becomes distressed. You need to know what you're going to say. And it might be, and we're all wired to be compassionate. So it might be something like, I'm going to stop recording the interview at the moment because I think we need to turn our attentions to what you've just said. Or it could be something like, what you've said is important, but actually I now need to put my doctor hat on or my clinical nurse specialist hat on to deal with that. You need to be very clear in your head which hat you've got on, and I would thoroughly recommend you to practice that. But you will bring depth if you have got an untrained researcher in your area asking the questions. They may not know in some of the responses that your participants give you whether something could be worth exploring a little bit more. So particularly qualitative research, you want to get saturation of the data. You want to have no new themes when you get to your interviews. That's a whole additional topic, which I'm sure other people can very, very ably cover. Let me talk about the research in poorer resourced areas or lower resourced areas. There's a lot of global research now across the world in areas of countries which are very remote, very rural, don't have very much resource. I really recommend joining research communities. For example, the African Palliative Care Research Association, the African Palliative Care Association, has done a lot of work in how to get the best out of research in remote communities, but it will be the same in the remoter communities of North America. Some of our students actually have been doing research up with the Icmr communities right at the top of America. So don't let that put you off, but it's really important that you share your results and share your findings so that we can build this network. So use the conferences, use your national conferences to talk, to share, to listen, to present work. The withdrawing and withholding area of research, this is a wonderful area where it's a classic thing. You've got a passion for the subject, fantastic, but usually what happens is that actually you can break that up into 4 or 5 different research projects. But if you refine your question, you're very clear the element of withdrawing and withholding that you want to look at. Research is an ongoing professional thing. You spend 1 or 2 years doing one project, you get some answers, you go on and do something in the rest. So I think be brave enough to break your ideas down into smaller chunks, because in my experience, it's the smaller discrete projects that yield results and keep you going. If you start off with something big, it may founder and then everybody will get very demoralized and research will be lost. And all the time, again, is it ethical? You've put lots of time and energy, involved people, and actually that research isn't going anywhere. That starts to feel a little bit uncomfortable these days. Parents and Ascent definitely agree, haven't got anything to add there. Retrospective data, I don't think I've got anything to add there really either. What was the other one? Oh, potential harm. Yes, where we started. And I think, as I said, I think you're right, everything has harm, but it's relative harm. And is the potential side effect of a medication, for example, justified because of the overall aim of that project? But that's where you use your ethics committee to help you decide, because people who will look at the proposal will be weighing things up, and they may want to ask questions, but they're asking questions to think about the safety of the patient. Go back to the Declaration of Helsinki. We need to protect our patients, but we need to do research as well.
Thank you, Fiona. Thank you, Dr. Santosh. We have 2 more minutes. And
so then, no, I'll just go over the questions, and I think somebody has been very good. They have answered some of the other questions themselves. So about hospice, if you don't have an ethics committee, please have one, number one. And secondly, you will know how to make it, okay? And say also, if you don't have, somebody has written later on that you can go to, there are private ethics committees which are formed like that. You can go to them, or you can go to any institution. If consent is taken prior to admission, can't we proceed with the research pertaining to, you can, retrospective can still be done, like I said, but I'm talking about future retrospective, you can still do it. A layperson is always an important part of the ethics committee, and they should be there. I have been told to use the research assistant for interviews. Yeah, you can use it. If you have research funds, then you should be able to do it. ICMR says initiate study after obtaining approval of protocol by ethics committee. Yeah, that's what I said. I mean, I think they have written that. I mean, this is there and you can follow that. Yeah, and 50% should be at least. Yeah, they have given everything. You know, like for example, the head of the institute cannot be the chairperson. You know, and so member secretary should be from the institute, but chairperson should be from outside. So I think we have covered most of the things, and it's good to see a lot of interest. And in IAPC conference in February, there is going to be a pre-conference workshop which Anjum is leading, and you know, people who are interested. That is only on informed consent. I should also mention there is cross-cultural difference in informed consent taking. In 1986, when I visited Memorial Sloan Kettering, and I was in palliative care with Kathy Foley and Subhas Jain, if some of you know him, you know, the ethics committee, the informed consent form was like 40 pages. 40 pages. And when I came to UK a few years later, UK didn't have that big, but it was not so small. You know, it was still 5 or 6 pages. In India, most informed consent forms are 1 page or 2 pages, you know, maximum 3 or 4 pages, you know, but a lot is done like that. So there is cross-cultural differences are there, but many places they give the person 24 hours, 48 hours, 1 week time to read and get back. Sometimes in India, they ask them to make a decision there and then. It should not be done. You should never force a person and never take their thumb and take a thumb impression. Give them some time. If you do research ethically, you can get a good night's sleep. That is all I would like to say. Thank you very much.
Thank you, Dr. Santosh and Dr. Fiona. I think sometimes 1 hour passes like this, and we can't imagine that how much we have gained in 1 hour. Everybody is so happy, and almost 137 people have joined. And I can see Anjum. Anjum wants to say something about the Anjum. These are the maximum people attending today. So you can, if you want to announce something, you can announce. You can open your mic and announce. You can take 5 minutes extra. We have just taken 2 minutes extra, but I think it was a wonderful, Fiona and Dr. Santosh, for giving your time and your energy. I think you have taken a lot of time and a lot of energy, and most of the doubts, many of the doubts of those youngsters, I think you have cleared so beautifully. Dr. Santosh, as always, Dr. Fiona, as always. And thank you very much. Anjum, please tell something about the conference. What you want to say about the conference?
Thank you, ma'am. Thank you. So just thank you for that time. I trust you, Dr. Santosh. Just to announce that we have a pre-conference workshop headed on the ethics of informed consent and clinical practice in palliative care. It will be held in the afternoon of the 10th of February, led by Santosh Chaturvedi sir, Yoris Gilin, Dr. Charu, and I. And in the main conference, there is a session on the ethics and clinical and legal aspects of withdrawal and withholding life-sustaining treatment. That will be led by Naveen Salins, the ICMR person, the ICMR expert, Dr. Roli Mathur, Dr. Dhwani Mehta, the lawyer, and clinicians, Dr. R.K. Mani and Dr. Roop Gursahani. So and apart from that, from the research aspects, there are several sessions on evidence base and the application of those in our actual practice in Indian and non-Indian settings. So I think there'll be ample scope for all of us to learn about the ethics of research and clinical practice. Please do register.
Yes, we will register. Everyone will register. Okay. Thank you, Dr. Fiona, once again, and Dr. Santosh, once again, for giving your time. And we understand, but this 1 hour was very, very important and very crucial, and we have captured all the whatever you have said, we have recorded, and it will be available on the IAPC website. Those who have missed some part of the lecture, those who have joined late, please join. Please, you can visit IAPC website and see whole of the lecture. Thank you once again. Thanks a lot. Good night.